so you know.
Chris is famous for putting on shea butter before our sessions.
That's the only thing I'm famous for shea butter.
He literally has like this tub, and he just puts it on his knee and just like rolls it around, and then rubs it on.
Yeah, you don't want ashy knees, especially on the big screen.
That's right. Okay, so to kind of review here, this is where we're going to kind of head. We're going to assess your joint workspace, so we're going to do full knee cars and see which one we got. We're going to do capsule workspace and just test rotation. I'm going to test that both passive and active. And then we're going to palpate the deeper structures, muscular structures around the knee. And I'll get more into that and why we're assessing those when we get there. So without further ado, let's do our assessment. Okay. So full knee cars, you can do them lying down, you can do them seated, whichever.
So this is the test. Because if I say, what's a knee car?
Yeah, we'll see if he's done his...
all week.
Oof, lots of crepitus. Let me get real close here so you can hear that.
What is crepitus?
Crepitus is like, yeah, it's like that noisy. It's a type of inflammation, and it can be helped. I don't know if this will like ever. I can't say like, oh, we can get it to go away, but cars and motion definitely helps with crepitus.
Is crepitus bad?
Is crepitus bad? I mean, if you like move your wrists around, like we all kind of have it in certain places, but if it's not painful, I would say it's not like bad, but I mean, it's something like that we can use is like, oh, there's less crepitus. I don't know how I would like gauge that, but how's that feel?
Good.
Go one more with the internal rotation bias. So it's still like a little shaky when we go, but this is definitely better. Okay, so you can plant there, and let's see what our active rotation looks like. External's always been better. Internal's definitely better. Yes. And then we'll go a couple more here and just see what we got. So you can see like where it's probably tough like on the floor on Zoom, but you can see where the knee stops and then where the ankle kicks in and where he definitely wants to like shift at the thigh. Like that's the end. And that's the end. Great. All right, so go ahead and recline and we'll do our passive assessment. Okay. So just grabbing the hold of the whole knee here. Sorry. Oh, I thought I scared you there. Thumb on tibial tuberosity and just assessing that internal rotation. We finally have actual motion in that capsule space.
I've been doing my homework.
So
very important.
Before there was absolutely zero rotation when we started. So that feels good. And then external hasn't necessarily been like a big problem. So we've been focusing more on the internal. Any pain or anything in there?
Nope.
This feels a little. Stretch on the inside, anything? Great. Okay. So yeah, that feels pretty good. And we'll go through, we can check our patellar cars here. Keep that, you're good, relax. Keep that knee nice and extended so you can get some motion out of the patella. So he has a huge scar on here from where the tendon ruptured in surgery. So we do some FR work on that the last couple of weeks, or we have done. It's still like a lot of tension coming, pushing that patella laterally versus pushing that patella medially. Moves much easier and a little more, and then a lot of resistance coming laterally. So we can actually even just start here and pulling on this medial tibial, patellar stuff. So I'm just gonna grab the patella and just pull it laterally for a couple minutes and just kind of start priming that connective tissue on the medial side and go from there. Any pain or anything in there?
No.
So this is just kind of where we'll hang out and start. So we like to see equal motion laterally and medially with the patella.
So if my patella has a hard time going laterally, does that mean anything about like my muscle tissue, my contractile tissue, in terms of like what it's using more?
No, that's kind of hard to say. But I mean, there is a lot of tissue on the medial knee regardless. But I would say just based on like other things, oh, that changes it dramatically. Based on other things we found being like, one, like your scar here. I mean, even if we pull like the scar, there's way more motion if I just slide the skin that way. It's very easy. Much more resistance if I just pull the superficial layer like that. Like it's completely different.
If there's something just with like
Yeah, so like the
line itself over, maybe has anything to do with that numbness that I've experienced.
I mean, potentially those might be two different findings, but again, just from like that superficial layer of fascia, like if I just keep pulling this way, it's totally different than like, I wish I had like a helmet cam on, because you can see like how much more tissue I can push that way versus that way. So I can even just like, this is where you can use the cups on your own and pull it, like grab a cup and pull it that way.
What about if I put multiple cups on this side?
Yeah, I mean, you just need to make sure that there's a direction, like just sucking it up is different, because that's not the direction. Like I can grab stuff,
Right, then I need to pull it.
but you need to give it the direction, which would be that way.
Like I need to do like a 2 minutes pull, so not just the lift of the cupping itself, you need to actually.
Yeah, like the cups are just easy because you can actually pry the cups in the direction that you want.
Okay.
So like just put one cup or two and then pull it gently that way, and it gives that tissue the direction.
Okay.
As far as like this tissue that we're specifically talking about. Which, so like if I wanted to get like a twofer, I can drive like the scar over and pull on the tibia, the patella, and just draw more tissue into lengthening laterally.
So you're pressing on the patella tendon?
I'm pressing, like if you were to look at his scar, I'm just putting my thumb on top of the scar where it is like the tightest chunk,
Yeah.
and I'm just guiding that stuff over. Like if I could pinch enough of it, I could just pull it. So I'm just pushing it over, and then I'm just taking this hand and grabbing the whole patella and just pulling it towards me. So I'm just driving everything this way. That's it. But like you can just feel like the stuff on top of this patella does not
Yeah.
want to go. but I can move a lot of tissue that way.
That's true.
Because like you can just see how nothing
Yeah.
pulls really. So that's where we're just trying to guide tissue. Is this our main priority? No, but we found it right out of the gate, so I might as well give it a little love. So we'll go a little bit longer here, and then while I'm down here palpating in full extension, we'll get into the articularis genu next. Does that make sense?
Yeah, because you're trying to get the connective tissue to be able to move laterally.
Yeah, so we're trying to send the signal to the connective tissue about length and like which direction.
Yeah. Break up any scar tissue.
Yeah, we're not really breaking things up. Like we're just telling this tissue exactly what we want in what direction. So that signal doesn't really occur until around 2 minutes. And then that mechanism that's called mechanotransduction sends the signal to the nervous system to send fibroblasts and tissue to this area, and then that's why we keep guiding it and telling those fibroblasts what we want them to become. Does that jive? Any questions? Great. Austin, Beatrice, anything? Okay, so let's say we've done our stuff. Anything? I hear some rattling. So we're going to work our way down into the palpations. So we just randomly did the superficial fascia up here. And so we'll get into the articularis genu. So I drew a little diagram here. I don't know if everybody can see it, but it's the anterior view. It's this purple structure here. So the reason why I wanted to hone in on these two muscles is because they are the deepest structures around the knee, and they are a feed-forward muscle tissue, meaning they give the nervous system information about speed, length. So if there's any dysfunction in the knee, like especially with this guy having poor rotation, the popliteus isn't giving the nervous system information about rotation because it can't move and activate. And so with the articularis genu, it's the deepest thing down here, so this might be kind of uncomfortable when we get there. And that's going to give us length about extension, or sorry, flexion. And Chris has been, had experience with closing angle joint pain and restrictions, so this will be kind of a huge player. And so I just want to see, I wrote down like, I want to palpate to see like what these tissues are feeding forward, like what information are they giving to the nervous system? Like are they locking up? Is there a lot of immediate tension in there? We'll just kind of palpate and see what we got. So obviously this is a very deep structure. Knee has to be in full extension and relaxed. And then we're going to get layered out of here really quickly. So there's not going to be a huge amount of flexion before I'm not even close to that tissue. So with that, brace for impact. So we want to be careful too about like the bursa that's up here and make sure we're not squishing that. So I might just take my time palpating down here because our boy is thick. How we doing?
We're doing something.
Yep, we're not even close, so. So again, I might use some isometric ramping to kind of get this tissue to kind of contract and relax so I can kind of sink a little deeper through there. So I might just have them go ahead and raise your leg off of me real quick and flex this stuff and push me out of there. Yeah, give me a little more. That. Cramp?
Getting there.
Go ahead and relax. So even when I'm palpating here and I say, hey, lift your leg, I don't feel my thumb get pushed out. So I don't feel like all the quad tissue coming on. So we're going to use that as feedback. And so now I want you feel me digging into your quad here, yeah? Push me out of this exact spot. Nope. More. Extend. So you can see him cheating, like he's pushing like that. He's raising, like he can't give me this spot to push me out. And he's cramping. So again, we're using this as feedback to be like, oh, okay, like we don't have a lot of connection, like to terminal extension, which again is articularis genu. It's going to do those last few degrees, and so maybe that's part of our findings. You okay there? Yeah. Okay, back at it. Okay, we're going to palpate back into there, and again, we're still ramping. So I want him to be able to flex the quads and push me out so I can sink in. So you feel me here. Mm-hmm. Extend your leg. That. Keep coming. More. Push me out of here. Pull your kneecap up. Good. Relax. You're getting it. Give me one more. Right here. More. You're getting it. Keep coming. More. Good, relax. We're getting it. One more for good luck. And then I'm going to follow this one all the way down. Okay, go ahead and push me out. One more. One more. So I can also, because my whole hand is like grabbing his thigh, I can feel like the medial aspect of the quads and the lateral, I can feel them like shaking and just like, you can see things just kind of trying to figure out how to do this. Relax. There you go. Okay. So let's try to sink down. You alive?
Yeah.
Okay.
Now, are you pushing in a certain direction?
I'm just pushing straight down at first because I want to make sure that I'm on the stuff. And then I'm gently going to just start to bend that knee and see where I come out of there. Relax.
Relaxing.
And I get pushed out of there pretty quickly.
What does that mean if you get pushed out sooner?
So there's, like, I have to push through all of his quad tissue. And the articularis genu is like bone, that thing, and then all the quad tissues. So that's why it hurts, is because it's so far down there. And then as soon as I move, like, we're lengthening the quads, so I get pushed out. Go ahead and slide down for me and see if I can get a better position here. Yeah, right there. Great. So, Austin practitioners, like, my thumbs are straddled so I can really get down there. Just as a heads up. Yeah, this feels better. You can tell by his facial expression we're there. Good. So right about here, I can feel myself. That's the absolute end range I can get there. So Austin asks if I'm feeling or assessing for mechanical tension doing this. So the answer. So we're not near an end range. I'm just assessing the length that the articularis genu will go. And so I can feel, so now, Chris, you can feel the difference between that and that.
Yeah.
Or you can feel me pushing up. So assessment, I'm pushing down and I'm like strumming to make sure I'm on the structure. So I do that by, I'm going to use one of my favorite words, pedunculated. So pedunculated or pedunculation means like there'll be like a big lump of tissue, like for the, like I can strum over that rec fem, like I feel just like this big lump. This thing is very flat, so it's not as pedunculated. Again, one of my favorite words. So that's why I like go down perpendicular and strum and really make sure I can feel that. But also, I have to be aware or think of too, like if there is a knee dysfunction, which clearly there is, that tissue also might be less pedunculated because it's atrophied. So it might be really tough to find. But then I just have to assume, based on like reference structure and like things I feel, like I'm on bone, therefore like if I feel that hard, bony end thing, I know I'm on it. It just might not be like this big, or it's never really big, but I'll just know that I'm on the right area. So just something to keep in mind is like that thing may be atrophied if you do go down there. So again, perpendicular, find the stuff, and then we're going to find where we feel that length, and I'm going to switch directions upward, and that's where we're basically going to stay.
And why did you choose that position?
Because beyond here, I'm going to get pushed out. So the quads will lengthen, and I will no longer be on the articularis genu. You okay? So we'll hold here, we'll put in our input, and then when my thumbs get tired, is I'm just going to have them keep this position. You feel my leg on the back of your quad, or back of your calf?
Yeah.
Hold it there. I'm just going to back away. And here's our pales input. So obviously he's going to contract, push me out of there, so I'm not even going to bother hanging on. Nope. You're going to stay. No. Right there. Just hold there for a little bit and feel that spot. So stay pushing in here.
Does that hurt, Chris?
So this will be our positional isometric, just to gently load that stuff relax, right there. At the length we were treating, just a light hold, make him feel this stuff. And then you feel my hand on the top of your ankle here, gently push up. So this has been an issue for Chris in the past too. So my hand is just on his ankle and he's just doing further pales. I don't know if you can see, but I'm very lazy. Honey, can you turn the camera? Relax a little bit. So I'm using my thigh for him to pales against me, so I don't have to fight him. And again, we're just loading this stuff further and further, or harder, I should say. Relax. And I can feel Chris fading pretty quickly here. So I'm going to change the angle a little bit just by putting my arm underneath him. And then go ahead and gently kick me again. Great. So I've just changed the angle a little bit. And again, I'm just being lazy. Yeah, because we're training at length. It's that and also load bearing capacity. Great. So load bearing capacity because we are at a length and putting force through that tissue. Relax. Correct. Go ahead and slide back up. So we just lived in FR land In the patella, we didn't do the scar or the tendon yet, but FR, the articularis genu, and then at length, and using it to reinforce. So if you think about it just from the FR standpoint, like we use pales to kind of reinforce our input, and so we're using it in that regard, creating like kind of a blend of afferent, efferent flow, because in the past Chris has had a hard time extending without like using his hip. So we are getting better at him generating force through this stuff without using other things, if that makes sense. Like he's used to organizing and doing things not with this stuff solely, but like with a hip or a knee, and like, not a knee obviously, but does that make sense? So now we can come into, since we're still supine, we might as well do the patellar tendon. And again, his scar goes from like above the kneecap and like where that articularis genu lives, and then just above like the tibial tuberosity. So it's a pretty good scar. And it was a complete rupture, so I'm just starting right at the tibial tuberosity. Again, a vaulted position, and I'm just going to slightly, did that hurt? Slightly put this thing at length and just glide upward. I'm going to let this kind of fall. Closing angle. Anything in the back?
A little bit there.
A little bit there. Better there?
Yeah.
So we have closing angle pain restriction. He's also been told there might be a Baker's cyst, so keeping that in mind. So different kind of closing angle thing. Gently kick up into me. So here's where we have an issue. Go ahead and relax. So before his leg was straight and he could kick up into me just fine. Here is a little different. So he's at full flexion. Obviously I've got my hand on his knee and I say kick me. And the first thing he did was just push his foot up into me, but no knee extension. So gently kick your ankle up into me. Better. So this is tough still for him, like using the knee extensors at this, like his terminal length essentially. So again, this can be an architectural thing, like a load bearing capacity thing, because we're at length loading the knee stuff. But also, this is very difficult for him to like connect with. So we got trying to just create information here, and we're just going to hang out here and make him work. So here's like a blend of like a couple inputs. And I can feel him like revving on and off. So relax.
I didn't want to hurt you.
I'm just holding his knee. I just want to feel what it's doing. I got my other hand on his thigh. And then obviously I can use my leg here to control. But I can feel if he's like trying to use his hip in any way like this, and I'm preventing it, or I can just feel it pushing in certain ways. So I'm just grabbing him as much as I can to feel what's going on. So go ahead and kick me again. And like right now his leg is drifting this way. Go again here.
Try this one. Let me see if that helps. Is that any better?
A little bit. So again, like we might stay here for several rounds just to like, again, flood his nervous system with like, hey, I want you to be able to use this stuff at this angle.
And you can see from here.
And you can see him shaking.
Yeah.
Like watch my leg bouncing. And that's just him figuring it out. I can also feel it just totally fading. Relax. You okay?
Yeah.
Relax. Or do you need a break? And I can also use that as like a Pale's test to see if we get more range of motion and or if there's any closing angle pain. I can feel a little more range. Do you have any? I can feel it right there. But we're done here. Because this seems to be this is our 4th week, and we seem to be getting the same restriction in the same spot. So do you feel any length happening under my hand here? Like any kind of stretching?
No.
So he doesn't feel any lengthening in the knee. So that also tells me like, okay, there's no connective tissue really coming online to provide the sensation of we're stretching. So I know we still have room, but I'm not going to push it because there is like potentially the Baker's cyst and it hurts. So there's no point in pushing that further. So we might be done here and move on to the next. So let's flip over. That's you flip over, not me. So we're going to palpate the popliteus. So we're going on the back side. Again, it's a deep structure. It's a feed-forward structure. This one's more rotation. So it does medial rotation of the flexed knee. If anybody's had this palpated before, it is a peach. So I apologize ahead of time. I'll try to stay out of the way here, so just bump this thing out of the way. So flex foot passively, get that thing nice and loosey-goosey. Again, flex knee, and we're going to palpate through the calf, through that. So we're going to start on the lateral condyle of the knee, and we're just going to sink through that tissue, and we're going to strum our way down, and we're going to use rotation of the knee to kind of palpate, we are going to palpate the popliteus, and again, see what we got down there. So I don't know if you can really see. Yeah, you can move it if you want. Maybe like this angle. So I'll just come up in her. Yeah. So again, I'm just going to sink in there. I can definitely feel it. I am strumming over the popliteus. And this, like I said, this can be pretty nasty. So I'm on it. I'm going to switch my hands here. Refind it. Okay. And then we're going to rotate externally. There we go. All right. What's that? Unfortunately, yes. It's pretty awful.
Feel like what? Terrible?
It's a gross feeling.
Oh, because it's in your fossa, so it hurts.
It's also deep, so I'm like pushing through his big calf muscle too. So anything deep, because you have to push through a lot of stuff,
Yeah.
it's not a fun day. And I've also been told that I push pretty hard. So it's also because obviously I don't work on this very often, but on myself. So I forget how easy you can get to these things sometimes, but I don't know. It's gross.
It's like nauseating. That's how I feel.
Yeah, there's a handful on the body that are just like brutal. This, I think soleus for me is one that makes me like literally gag and tear up. So again, we're just psoas, medial pterygoid, like the hip joint capsule, like pectineus, like deep in that stuff is never a good day. Anyway, so here we're doing FR of the popliteus, try to gain some length in lateral rotation. Again, that's still going to play into that connective tissue and stuff when we started, having the patellar motion not be able to move laterally, so we're still kind of affecting a lot of the same stuff.
What does FR stand for?
Functional range release. So that's the soft tissue therapy we are using. So I'll switch here. Obviously you feel me externally rotating your knee. You feel my hand on your outside of your ankle and your foot on my arm. Rotate into those things. Like, give me more from the heel, that. Relax. So I'm going to repalpate there so I can make sure that he's using the popliteus actually, or among other things. So again, you feel my hand here. Start over. And go again. Good. Give me that heel right here. Yeah. Good. So don't let me push that heel. There you go. So really trying to use the ball of the foot and the heel to create that torque and that rotation of the knee. Any pain or anything? Great. Relax. Gut, gut, gut. So another assessment, like while we're here, is knee flexion. And not even close to full flexion where we were supine. But you can see him rocking and getting lumbar in there. So we can, again, not on the schedule, but we can treat this a little bit as well. So I'll just hang out here. Gently kick into me. Plenty. And then I'll see his lumbar still move. So go ahead and relax. So here's how I kind of like to teach people how to do, depending on like their skill level. Like Chris is a very aware person, knows how to control his body. If this was Joe Schmo Magoo, like I might not have them try this. So I'm gonna have Chris block his own compensation. So give me a posterior pelvic tilt. And I can already feel pressure in leg extension. So that's all I want. Keep kicking me here. And the more you give me here, the more you gotta hold that. So now I'm trying to do, again, a few things at once. We're loading the knee. We're getting that afferent, efferent information flow where he's learning how to extend from here. He's blocking his own compensation, so we're just flooding him with information right now. Kick me a little less. Be crazy here. He's in a different hip position, probably part of it, so rect fem is probably going to be a big part of that. So now I might give him like a third cue, because now we're thinking rect fem. We see the compensation here, and we know we have knee stuff. So we're going to go 3 things. So tuck here, and you're going to feel automatically push into here. Gently kick me, and then gently drive your knee into the table. So now we're getting like rec fem at total length because he's flexed. And now we're getting all the quad stuff, but again, we're still blocking here. So we're teaching the nervous system how to decouple at the same time, essentially. So I'll kind of use this strategy throughout the body if the person is capable of doing so. Not everybody can be like, rub your belly, pat your head, and blow me a bubble. Relax. Relax everything. Good. And again, we can use it as a positive PALS test and get a little more range of motion. Any closing angle pain? And less motion here. So I might even switch this and just hold here and just cue the lumbar. And like, again, just train the nervous system to decouple. As in like, hey, you're here, so go ahead and just tuck. And draw your pelvis away from the table. Away, so tuck that way. Other way. That way. So if he's doing this right, I should feel pressure into me. But not a lot, because we're just aiming up here now to kind of, we're just toggling, bouncing back and forth now. Good and relax. Any closing angle pain? Great. So now we got, do you feel length at the knee?
A little bit.
Okay, so we have some stretching now. And then if you notice, we gained some range of motion, and now his back moves at a further length. So instead of it being around 90 degrees, we've acquired more length. And you can see him gently bounce, but that's the length we established. So we can kind of keep going if we're getting positive tests of like PALS, whether you're going to do it from here or all 3 or 2 or 1 or just from the knee. Like you can just keep going positive tests until you start, like he gets pain, or until you just like his heel's on his butt and then you're out of room. So we can go a couple more there. And again, being lazy. So I'm just leaning on this. I can feel I got a good view of the lumbar spine. Any pain? Good? So gently kick me, because I can feel the restriction in his knee. Like I don't see any lumbar stuff, and I feel the rate limiting tissue is the knee. So go ahead and push into me gently. That's it. Great.
Is that what you want him on my back?
Okay.
That kind of a push?
Mm-hmm.
Or that other stuff?
Correct. Keep gently kicking me here. That, relax. Relax all the way. Just kick me from the knee. Great. So I stopped him because I just started seeing other stuff go. Keep that same effort. And we're like 30%, like very low intensity. Go ahead and ramp that up a little bit. Give me a little bit more. Yeah. And at this percentage range, you can see them kind of start to bounce. So we're getting fatigued. So if I ask for more, you're going to really start to see him shake. Obviously, I can really feel him shake.